Thanks very much, John. So we're going to shift gears a little bit and talk about some clinical symptoms that I know are near and dear to many patients' heart. I talked about this a little bit last year. We've pretty much analyzed all of our data. We had some trouble analyzing some of the data because we had logistical problems, which led us to wish that we had really been able to assess more patients comprehensively. But I'll talk a little bit about that as the talk goes on. We talked about the headache symptom in Chiari, and of course you've heard enough about the fact that it originates most often in the occipital region, occurs with a sense of head pressure or retroorbital pressure, neck pain, muscle spasm, retroorbital pressure, nausea, dizziness. All these are common phenomena that all of you appreciate very well. There are also a lot of secondary symptoms that the paper that Dr. Miller had put out in 1999 amplified and hopefully brought home to a lot of physicians out there the other very common things that patients with Chiari suffer with. Nowadays, it's an important issue because medical practice is very symptom-oriented, and many physicians, I know you all have had the experience, if you go past maybe 3 symptoms, their eyes begin to glaze over, and they start thinking about they're writing their prescription for antidepressants and sending it to a shrink, and sometimes wishing you would maybe see another physician. My wife had the experience going to a local neurologist. She has a little cervical spondylosis. And so I wasn't helping her too much, so she wanted to see a real neurologist. And so I had this friend of mine, so I said, why don't you go see him? He's very good. So she got in the office, and after took her about 5-10 minutes to explain her problem with pain in her neck, radiating down her arm, and she said, well, I also have this little bit of numbness and tingling in my leg. He said, stop right there. He said, we'll do that another time. You're really only allowed 1 symptom. And so she wasn't very happy with that. And she got better on her own pretty much, so. But she's still talking to me, by the way, so. So patients with Chiari, and this is kind of the difficult thing to deal with because there are a lot of symptom areas that are important. Limb pain, sleep disturbances, gait, balance difficulties, numbness and tingling in the extremities, a lot of dizziness, vestibular, eye movement disturbances that are very subtle, and vision disturbances. In that 1999 paper, we talked about segregating. You already heard from Dr. Sansour about the occipital headaches. It was very, very common. And the other symptoms that we're going to focus on are a little bit down here, not quite so common. And I think if you look at various groups of patients that have been studied, the symptom of impaired memory and concentration comes up into close to 40 to 50% of the patients. And that's held true even as we've assessed many greater numbers of patients at the Chiari Institute since this original paper was published. There hasn't been too much investigation of this area. It's been certainly with the surgical issues and the severe headache and syringomyelia, perhaps some people might think more serious issues to think about, but this is an important one. Affects individuals' daily life. Certainly at an incidence of 50% of incidence as a symptom complaint, it raises to importance. But there's been very little hard look at this area, and we're hoping we contribute a little bit more to it, but we're more impressed with the inadequacy of what we were even able to do that leads us to need to do quite a bit more. Dr. Rosner in 1999 had looked at 36 patients pre-op and 20 post-op. He assessed a wide range of cognitive complaints, more or less in taking a history and asking about various kinds of symptoms. He also did some cerebral blood flow analysis with SPECT. It's a kind of technology in 16 patients, and suggested that there might be some abnormalities in cerebral blood flow, but that was kind of the extent of the analysis. Dr. Oro, in his review of a large patient population of 265 Chiari patients in 2004, also looked at self-reported complaints, and very similar to studies that we had done, and certainly other people, upwards of 45% of patients had word-finding difficulty and various kinds of cognitive difficulty, including fatigue. There are also, not directly Chiari related, but there's numerous studies have found that acute and chronic pain states interfere with cognitive function, most evident in tasks of attention, memory, speed of processing, and executive functions. And there's more attention being paid to this, and probably will come a little bit full circle to that, because I think we have some evidence that there may be some of these factors going on with the Chiari patients as well. And a lot more kind of needs to be done. So about 50% or more than on average of Chiari patients complain of this cluster of neuropsychological symptoms that they have coined a term of brain fog. It's not a unique situation with just Chiari patients, because we see this in MS, and this brain fog term is so descriptive of the problems that go on, but it's not very specific. So you have the patients that have had serious head trauma will complain of brain fog. MS patients will have a similar complaint. It is a very kind of similar gamish of symptoms that are sometimes difficult to analyze. And what do they include? Memory disturbances, word-finding difficulties, difficulty with attention and focus, being able to stay on task for periods of time, cognitive blunting, just not being able to get to task, and certainly elements of depression and anxiety with not only these symptoms, but other symptoms that are going on. So although this symptom of brain fog is frequently reported by patients in a clinical setting, and is certainly well known and sometimes feared by clinicians, we have very little empirical knowledge regarding this syndrome and what this is. And so really with Dr. Millerat's impetus to kind of try to find out a little bit more about what we could understand about this, we devoted some time, had a PhD candidate person, Tracy French, who had an interest in this, and really kind of put it as part of her doctoral thesis to work on a project in which we attempted to characterize and document the presence of neuropsychological symptoms. Again, a kind of a symptom survey questionnaire-like look at what symptoms a patient's categorizing and complaining of. But also we wanted to attempt to uncover some cognitive abnormalities that might explain the clinical complaint of brain fog as it occurs in patients with Chiari malformation. And it wasn't as easy a task as we had anticipated. In the end of the study, and we've just completed finally an analysis of about 70 patients altogether, and as often happens in clinical trials, you start out with one kind of approach, and you find you may try to change things. There's a good and bad aspect to that, but we started off looking at a subgroup of patients with a very, very intensive cognitive battery of testing, and this took, I don't know if did anybody here in the audience go through the testing, the Cantab testing? Okay, I thought maybe I'd have at least one hand, but we looked at about 20 patients, and this was kind of an arduous task. It takes about 2.5 hours. That was the good news and the bad news, because although we got it done in 20 patients, wasn't kind of a very high number to assess, to reach the power of analysis that we would probably need to show a lot of important statistical kind of power to the study. But we had a lot of logistical problems because we felt we had a captive audience at the Chiari Institute with patients, but patients that come to the Chiari Institute are pretty busy, even though they certainly can complain vigorously about the long wait times. We are moving people around to imaging and nurse practitioner assessments and neurologist, neurosurgeon, and we found many patients really didn't sustain, didn't have the time availability or were able to sustain a 2.5 hours worth of testing. So that entered in something we didn't really anticipate in the beginning, which was a selection bias. So some of the patients that might have been in more pain, might have had more fatigue, more complaints, they really couldn't handle the testing, and they had more clinical issues that kept them busy in other areas. So I think one important issue is this selection bias. So we did have, we're more likely to access patients that were interested in this, and I think also higher functioning patients who were able to go through all the testing. So as we got close to the time of the end of the study, we had hoped to access about 100 patients. We actually were going to do this pre- and post-operatively. But after a year, things were kind of grinding to a halt. We didn't access nearly enough patients. And so we started saying, well, we really have to find quicker ways to sort of do that. So we began using what is called an R-bands kind of screening. It's about a 20-minute testing procedure that we were hoping to look at actually as part of a side study we were going to do to kind of look at patients in extraction, cervical extraction, pre and post the use of traction. Some of the patients were having improvement in short-term cognitive things. We wanted to assess that. So we're sort of looking for a way to do a quick assessment of cognitive function. And we ended up in the end kind of lumping the whole group of patients together because we did a statistical factor analysis. Of course, we had the questionnaire on all the Chiari patients. So we cross-referenced all the testing that we were doing to try to see if we would find any difference among the patient groups and all. So we kind of lumped all the testing together. And unfortunately, we didn't have power enough to say that there was a difference between patients that had pain and didn't have pain, patients that complained of brain fog, didn't complain of brain fog. So that was a disappointing aspect of it. And but the patient group, as I've shown you here, so in the end, the statisticians told us we're not seeing anything coming through here that differentiates the groups of patients. So we tried to cope with that. But the group of patients had a mean age of about 37 years. Age range was from 18 to 60. We did not include children. I was interested to hear Dr. Brockmeyer talk about the cognitive improvement with young children with Chiari and improvements in ADHD kind of function parameters. We see that all the time, and it's another area that's worthy of focus. But we for IRB-related issues, we limited ourselves to just adult patients. There were 16% of the patients were males, and of course, as we're used to seeing, overall about 75% of our patients generally are women, and here there was a little bit of an overrepresentation. I think might represent the fact that I think women are more likely to participate and try to contribute to things than the male population, but so women were a little bit overrepresented. And the only thing we were, in the end, able to do diagnostically, we had categorized whether patients had tethered cord, whether they had EDS, and none of these things had enough power, or a group of patients were strong enough to enter into some kind of factor analysis. But we did then just look at patients with Chiari malformation, tonsillar herniation greater than 5, 75% of those cases, and patients with low-lying cerebellar tonsils. And it lumps in that whole Chiari 0 group, possibly tethered cord patients, possibly patients with EDS or minimal tonsillar descent. So there was about 73% of the patients were honest to goodness what everybody agrees is a Chiari malformation. We looked at self-reported variables. Patients reported neuropsychological symptoms, which I talked to you about earlier, about 43. We're really holding true, 43, 45%. All the studies are showing a very similar incidence to complaint of cognitive issues. We assessed the patients who we usually do with the OSHA or JCO kind of regulation pain scales, and the average on a scale of 0 to 9, patients averaged a pain at the assessment of themselves close to 4. So they were all on average in moderate, mild to moderate pain at the time we accessed them and the time we were testing them. And on an average basis, the Karnofsky score, which we use as a kind of outcome variable and also as a stratification of patients, patients at the level of 65 plus or minus standard deviation, there was 5, are patients that are significantly beginning to be somewhat disabled. They're not working effectively. They need some assistance with some daily activities, and they, in our mind, are very near to being possibly surgical candidates. And so the patients ranged, actually, we did have, I think, one patient that said they were almost a 0, which is almost not being here, to functioning really quite well. So in this first group of patients, we tried to be, as you oftentimes set out to do, very rigorous, and we didn't want any confounding variables. And as it turns out, sometimes with your inclusion and your exclusion criteria, you eliminate virtually all the patients you might want to study. But we were very kind of hard-nosed about this. We wanted to have adult patients, limited the high end to less than 65. They were patients with, we didn't want any dispute about whether they were Chiaris or not, so we looked at patients only with 5 millimeter tonsillar descent, and we wanted to exclude patients that had had any prior brain surgery, head injury, vascular events, intracranial bleeding, or any kind of substance abuse or dependence on medication. By and large, these patients were taking very minimal, if any, pain medications. Again, that may have entered in a selection bias as well. But we got only 20 patients, and as I said, we were faced with wanting to cut to the chase a little more. So what we did is we said, we're going to just limit. So we added, with this use of this R-bands and other kind of testing mechanism, we added another 50 patients in a relatively short several months of screening, and we had that contributed to this sum total group of 70 patients. And that included symptom surveys and various other testing mechanisms, which I'll show you. So this the Cantab is, as I said, it's a comprehensive battery that's used to identify and differentiate various neuropsychological deficits across cognitive domains. So it's very, I'm just going to run through these quickly. They're kinds of things that patients had to do. Subjects are asking this, all of the testing is done on a computer screen, and and every single testing mechanisms, the speed of the patient able to complete the task and the motor facility to be able to do the task with touching on a screen was assessed. So first the patients would have to be able to, we wanted them to be sure they had the motor skills to be able to interact with the screen. So they did some visual spatial testing, following and touching and the screen and touching the X, and knowing that the patients had motor skills enough to be able to do that, and they weren't paralyzed or weak enough that would inhibit their ability to do the testing modalities. And here's just some examples of the kind of testing. This is a simple test to try to match this figure. Figure is flashed up, and then after it gets increasingly complicated as time goes on, and these similar patterns are flashed up, and the patient has to touch the one that matches. And there are parameters that change as the testing is done. In other words, the initial stimulus is up for a shorter period of time, and the patient has a shorter period of time to make a right response. So there's every single testing mechanism had about 7 or 8 different parameters of time, and motion. So it's a very comprehensive sort of thing. And this is looking at paired associates. They flash up sequences, and patients have to find a similar sequence in the location and space. Again, similar pattern matching, visual search strategies with various kinds of time testing. And then there were other kind of reaction time testing, being able to reach up, touch, and follow the moving stimulus. This is another kind of interesting, numbers are flashed here. There's a 3, 5, 7. indicated at the side, and the numbers flash through here. When the patient assesses that they've seen a 3, 5, 7, they hit the button. So the numbers keep flashing faster and faster and faster, and they have to react when they see the sequence of numbers, and then the sequence of numbers gets bigger. So it can be a very stressful test. This is an interdimensional set shifting. It's not easy to say. There's a sort of, this is a tricky test because you don't know exactly what the strategy is. So some of these pairs are lined up, and the patient has to choose what similar color or the image, and it's not clear exactly. You have to find out what the strategy is for the comparison. So after you make a couple of errors, you find out what's wrong, and you have to, it's a very complicated test, you have to cognitively figure out what answer they're searching for, and kind of come up with the right answer. So I would not submit myself to any of these tests. It's extremely intimidating. And this is another similar one. It's maybe some of you played this as a child. You get a series of images here, and the person has to move the spheres in order to match I think Towers of Taiwan or Towers of whatever Babel. There's different names to similar games. Then other spatial executive function, looking at moving objects and trying to predict where the object is going to turn up next. So this is kind of just an idea about what kind of testing, how sophisticated the testing was, and how complicated it was. And in fact, that we had to get the statistician involved in it to just process all the various parameters, because it was actually dizzying to try to see whether anything was rising to the surface as a important finding. What we did come to grips with, and I guess I should preface it by saying we didn't find the good news, or the bad news, depending on how you look at it, we didn't find any global neurocognitive deficits in the patients that were tested that were statistically significant, all right? So that's kind of, that's what we hoped, that's what we were looking for, all right? We wanted to say, hey, they have this, and then this is characteristic, but we really didn't have statistical power enough to see that. But we did find some tendencies that related to the speed of processing information as well as the speed of the patient being able to respond that looked kind of significant. So when you're trying to publish a paper, you have to show some results. So we did struggle with the issue of how do you, if it's not statistically significant, how do you still kind of say there's some tendencies here that look real, but we can't say, hit the gavel and say that's really what it is. But so we did. That's why you need a statistician, right? So we looked at this, and we came across looking at confidence intervals and looking at what percentage of patients were actually outside of 2 standard deviation, the numbers of patients that were falling out. And again, this is what's highlighted in red that seemed to be significant. The rest of these modalities, we didn't really see any differentiation of patients. Patients that complained of brain fog didn't seem to do any worse than patients that didn't complain of brain fog. And as a group, they seem to have very similar, problems. And what we did see was these reaction times, simple movement, and 5, rapid sequencing kinds of movements that where the patients began to step out into, extending beyond 2 standard deviations. In other words, only a few percentage of patients we should see, and we seem to see that we are seeing a little excess in this area. So it's suggestive, but needs a little bit more work. Again, as I told you, we accessed another 50 patients into the group looking at this R-bands, and you get used to looking at these alliterative kind of. I actually talked to some of the psychologists, and they couldn't remember what R-bands actually stood for. So. You can ask, neurologists have the same problem too, but it's repeatable battery for the assessment of neuropsychological status. So it's a group of tests that you change a little bit, but you can come back and do the same kind of test repeatedly, so you can look at pre-surgery, post-surgery without having a real learning effect. One of the problems if you give the same test to patients, like a neurologist sometimes will say, remember apple, penny, table. All right, so I mean, after the patient's been in there 5 times, he knows you're not going to ask apple, penny, table. Maybe he's written them down. So that's a learning effect. So you got to change the things between the testing. So this kind of allows for that kind of mechanism. So we looked at these, and we did. There are different strategies that are looked at. Verbal memory. There's list learning. Patients are given a list of 10 items, and they have to try to duplicate that. They give a little story, and they have to kind of recite the elements of the story. There's a semantic fluency where a patient's given 60 seconds to name as many fruits, as many vegetables, as many animals as they can. Auditory attention, which is looking at digit span. And these are quite simplistic and interactive testing kind of at the bedside. And then some coding tasks where patients are given a little stencil with, it's almost a translational kind of thing. The little triangle means an A, and this one means something else. You have to try to figure out the coding as rapidly as possible and see if you can get as many as possible within a timed test. But it can be administered very rapidly, and it turned out to be actually pretty good. And so it was easy to do. We could repeat it with different variations on the theme so the patients didn't have a learning effect. And we began to do this a little more. And we did see that, again, when you look at the outliers here, story memory, coding, semantic fluency, and list learning, patients did begin to get out of 5 to 10% of the patients were having more trouble than statistically we would have expected them to have. So there may be something here. Again, we're looking at kind of speed of processing and subtle memory-related issues. Interestingly, there are other testing areas like trails. The patient has to kind of trace, has a diagram. It's almost like connect the dots, and it's a time test to see how many patients can do, and they didn't really fall too much outside the range of normal in some of this, and another, the COAD, controlled word association testing, which I'm not very familiar with, but that didn't really, again, as you can see, in this group, there were really no patients that fell outside the 2 standard deviations, even suggesting that they might be outliers. Now, the other thing that we looked at was